I'm going to go ahead and introduce our first opening remarks are going to come from Wayne Tormala, who's the Bureau Chief for Tobacco and Chronic Disease.
This is National Men's Health Week, and I'm also the Arizona Men's Health Coordinator, which means about 1 week a year we go into uber speed on men's health issues, and then it dies out again for a while. We do tobacco and all the chronic diseases. But I wanted to offer some special welcoming, and that the department remains very excited about the fact that we've partnered up with tobacco control and the behavioral health community. We know that, as many of you know, people with mental illness in Arizona have a life expectancy about 30 years less than the average Arizonan. And most of that's due to chronic disease, of which oftentimes, of course, is preventable. And we know we have up to about a 70–75% tobacco prevalence among people with behavioral health issues. And so that seemed to be the no-brainer about a year and a half ago, and Stephen and I and others met with the Division of Behavioral Health Services at Department of Health Services and say, if we think we can work together on this issue and make a difference. And so ever since then, we've really been putting our foot to the floor, keeping our foot on the accelerator and doing some initiatives, and we've had some good results. So I know we've been working through the Division of Behavioral Health and with the REBAs that but we have an enrollment rate of about 45%. So when you look at people coming out of the behavioral health system linking up with Ashline to have a 45% enrollment rate, in the tobacco world, that's very impressive, let alone when you blend tobacco and behavioral health issues. It actually exceeds the average across Arizona, which is more like 40–42% enrollment. So we feel really good about that. We also feel really good because we're modeling out some systems changes. As people come into the system, are assessed for tobacco use and have automatic linkage to the Ashline, then we know we're reaching folks. And Ashline is a state-of-the-art quit line, and we're very proud of that. And now we're very proud of the fact that we have such a strong partnership in the behavioral health community. Linking systems change to evidence-based practice is really the model we're looking for in all that we do, and this is certainly working thus far in behavioral health. Also, we're going to be meeting with the department or the Division of Behavioral Health and really looking at ways to partner other kinds of disease management programs. So we do a lot of work right now with chronic disease self-management, so getting into self-empowerment around chronic disease issues. And what we're preaching this week to men across Arizona in our Men's Health campaign it's not just that you don't use tobacco and that you eat right and that you get some activity that you can sustain 4 or 5 times a week, but also that you get your screenings, and then when you get your screenings and you have some issues, which most of us in the room will have by the time we're 40 or 50, and all of us will have some issues before we die, that there are ways through self-empowerment and through peer groups and looking at support that you can manage yourself quite effectively. So that's what we really want to preach at that point. Primary prevention and then secondary prevention screenings and then getting into disease management. When the health system is challenging for us, there's 2 major tracks. One is to sort of change the industry, change the payer system, incentivize wellness, and do all those policy changes that we all want to see at some point in our life. The other side, though, is to empower people. To know what the warning signs are, to get their screenings, and to know that they don't have to live a life of ill health and that they can be an author of their own life story. So that's our goal. So we're just, again, I want to welcome you here. I apologize for having to run out. I'm at a meter here for a quick getaway to the TV studio. And if I get a chance, I'll come back before you're over at about noon, right? Over at noon. Okay. Thanks a lot for being here.
Thanks, Wayne. We'd also like to bring up Lisa Shoemaker, who represents the Division of Behavioral Health, to say a few words from the folks over at Behavioral Health on how important this issue really is for all of us.
Okay, so I'm just going to be really quick and say welcome, and I'm glad to see you all here. As you all know, the tobacco cessation issue is a huge concern for our behavioral health recipients. We want them to live healthy and happy lives, and So we really want to commit to helping to reduce tobacco use because it contributes to so much disease in our population. This is part of our big adult systemic care plan this next year, so we'll be incorporating lots of steps, and you guys can be looking forward to seeing that. And we'll look forward to planning with you and implementing in the following year.
This will come back up. We've been working on this idea of bringing some behavioral health providers together to really talk about this topic more in depth, and the topic of tobacco and how it impacts those people who are diagnosed and struggling with mental health or substance abuse disorders. And this has been, as Wayne was saying, a project that started about 2 years ago. We're going on 2 years when we met with the Division of Behavioral Health to address this issue. So it's actually quite exciting now that we're having these summits. They'll be going on throughout the year to talk and provide opportunity for everybody to really discuss the topic. And we want to make these not just educational, we're throwing all the information at you. What we know is the system hasn't been real supportive when it comes to tobacco cessation. It really hasn't been part of the system to think about tobacco and getting people to quit. So we decided it's time to change that. And one of the things that has happened in Arizona since the meeting with the Division of Behavioral Health 2 years ago, we were recognized by the university, it's called the Smoking Cessation Leadership Center at the University of California in San Francisco. We were working with them on another project, and they were talking to SAMHSA about what's going on in Arizona. So SAMHSA has identified Arizona as one of the leading states in dealing with this issue. And they actually have come out, and several people in this room were part of what's called the leadership group to deal with tobacco and behavioral health. And that group is really working from many different perspectives on developing a systems change to deal with tobacco and reduce tobacco use and hopefully reduce that gap, the morbidity and mortality gap that we're seeing in Arizona. So I just wanted to give people a brief overview. Why are we doing this? Why are we here talking about this today? Because it's one of those issues that some people go, why? I still hear this out in the field. Why is tobacco so important? So I wanted to just do a brief overview of why we're doing this in Arizona. Let's see if we can. Back in 2003, and I'm sure many of you have read this report, the Freedom Report was released in 2003. President Bush commissioned a group of people to look at the mental health system and make some recommendations on what needs to be done to help fix the system. And the statement that Dr. Hogan made in that report, and makes fairly publicly in 2003, for too many Americans with mental illness, the mental health services and supports they need remain fragmented, disconnected, and often inadequate, frustrating the opportunity for recovery. And I don't know, even 8 years later, that's changed a whole lot with budget cuts and stuff. It doesn't seem like a lot of the recommendations that were made in that report have been able to move forward. But one of the things that we're looking at is this is one step we could take to possibly help really move the system forward. Some of the things Wayne had started talking about, some of the things we know about Arizonans with mental illness. Right now, those with mental illness and using tobacco die 31 years on average, 31 years before their peers who are not diagnosed, which is unfortunately depending on which way you want to look at it, we're either at the top or the bottom. We have the largest gap of all the states in the country right now. It is still the leading cause of death, even in the report that was put out. When you look at the leading causes of death, coronary and lung disease being the two most common, most of those diseases are still caused by tobacco use. In Arizona, there's still about 75% of the people in the public mental health system who are using tobacco. And that right now is, if we look at it, more like 6 or 7 times this has changed, since the prevalence in Arizona has dropped rather significantly. And SAMHSA's report that came out in the early 2000s indicated that about half of the tobacco in this country was purchased by somebody with a mental illness. So the tobacco companies are making a lot of money off a population that really has been taken advantage of. Many years ago, several of us in this room were part of a long process to develop a strategic plan for dealing with tobacco. So I wanted to kind of give you an overview of how we're dealing with cessation statewide, really focusing on smokers. And this applies to all populations, but we're talking about people with behavioral health issues here, but this model still works for any population we're dealing with, and really all the different pieces when you're looking at a system that have to take place. So we're looking at the social networks people are in. How do we market? How do we really reach people with messages? Involving the community, the advocacy groups, those folks who deal directly, not necessarily as providers. Service providers we see as a separate entity because they're often paid to deal with this, whereas community groups oftentimes are dealing with this on a voluntary basis because there's a community need. And then making sure that there are services. Currently, the state is paying for the ASH line as its primary focus for cessation services, and then focusing on getting people to quit, and if they relapse, getting them back on the horse. So when we look at this, there's many pieces that the Bureau of Tobacco and Chronic Disease are juggling to make sure that we're being effective in cessation. The Behavioral Health Initiative is what we've been calling it for the last 2 years. What's happening with that? That stage one was really focusing on people in the public mental health system because the smoking rates tend to be higher in the public mental health system than those people in general behavioral health services. And really looking at an integrated model that increases access to tobacco cessation, including treatment and medication, and really looking at both on-site and off-site support services. Not everything can be done by a quit line. So that's one of the things that we recognize, and in talking to the folks who are out there dealing with the members of the behavioral health community, is cessation really needs to happen at differing levels. If somebody's inpatient or living in a residential facility and their symptoms need management at that level, chances are a quit line is not the best place for them to get cessation help, and there really should be on-site cessation services. Intensive outpatient treatment, again, we're looking at somebody whose symptoms are fairly unmanageable at that point, that they're having to come to services every day. Quit lines probably still not the best place. Should probably be built into the services at that point. And it's not really that hard. One of the things we do as a team is really help a facility struggling with this identify what do we need to do to offer services on site. Because tobacco is an addictive substance, and treating addictive substances really isn't that different. We're just adding another chemical to be dealing with. And people can bill for that if you build it into the substance abuse programming. In outpatient treatment settings, this is where quit lines become probably a more viable option for people, and really building a relationship with the quit line on making referrals, because referrals, what we find is referrals from a center, more people will enroll if you actually refer them as opposed to just handing them a phone number or telling them to call the quit line. So we work very closely with facilities on how to build in referrals. And then when you're looking at people who need case management or just medication management, the quit line oftentimes is the best option for them. So we have to recognize quit line doesn't do everything, and we need to partner with everybody in the community, and especially with providers, on making sure people have access to treatment. One of the things that we're doing different, we received some funding from the CDC, Bureau of Tobacco and Chronic Disease, applied for some additional funding for the quit line. We specifically wanted to focus on the public mental health population. And in doing that, one of the things that we thought we would try, because there's been some great success, in involving pharmacists in providing treatment. Because one of the biggest concerns we hear out in the provider world is we don't really know what happens if we start messing with meds, and what happens, if we take somebody off nicotine, how much med adjustment are going to be. We don't really know enough about the interactions between some of the drugs out there and tobacco, and there's this fear amongst providers it's kind of an internal fear that people don't publicly acknowledge, but in meeting with psychiatrists and some of the other prescribers out there have realized that there is this fear about pharmacotherapy and how we deal with this. So we thought we'll build in this option of allowing the members to actually talk to and use a pharmacist as one of their coaches to talk through this. And the pharmacist also will have the ability to work with the providers directly, working with the prescribing psychiatrist, or if it's a general general physical med doc, they can also do that. And we have hired now a pharmacist who has a very long history in working with pharmacotherapy for behavioral health issues as well. Marty Fankhauser is in the back. She's our pharmacist. She's got a great history in the behavioral health system. I know up here in Phoenix, people probably don't know her name. In Tucson, she's very well known. So we're very excited to have Marty on board because her knowledge and experience is wonderful to be working with. So Marty is our pharmacist. We've also, as part of this, decided to hire licensed behavioral health therapists who can work directly, who are familiar with the system, and can work directly with any client who may be experiencing some difficulties around their symptoms for their mental illnesses as well as their tobacco use. And both Milka Pavlik is here with us. She's our full-time behavioral health therapist, and Barbara Miller. So there's faces for names. These are the two people who will be dealing with the folks who are struggling with some issues. One of the things we do like to point out, and this is one of the things I'm sure you'll hear and we have concerns around, is not everybody who calls the quit line and is diagnosed with a mental illness needs a specialist. 90% or better of the folks who call us who have been diagnosed with a mental illness do fine with any coach. And we've been, and may not be a surprise, but since the quit line has been around for the last 17 years, we deal with a large number of people in the public mental health system who call on their own. And one of the things we're hoping we change over the course of this year is to hear less of them say, my case manager says it's not a good time for me to quit, but I really want to quit. Or I told my psychiatrist won't let me quit. We would really like to change that as a message because as a client advocate, it still rattles me when I hear that, to know that if I had a family member who was in the system and using heroin and went to their psychiatrist and said, I really want to quit using heroin, I don't think the psychiatrist is going to say, I don't think now's a good time for you to quit. So when somebody says they want to quit using an addictive substance, I don't think it's very responsible of any provider to say, now's not a good time for you to quit, unless they have a really, really good reason and can document it. The reasons we hear aren't all that great. So this is one of the things that led us to this whole idea that we would really like to see some changes within the system. One of the challenges we know we're facing is behavioral health has a higher prevalence rate amongst staff members. It's still about 3 times what the general public rate is. In Arizona, last time a survey was done, it was right around 37%, which seems fairly high, and that's just amongst those people providing services. So we know there's a challenge there as well, is that tobacco use is pretty ingrained in the environments that people are working in. So one of the things that we're doing today, our first summit, we like to call these summits or training experiences for people, is to address some of these fears and some of the questions people have. And we have been very fortunate to have Dr. Prochaska from the University of California at San Francisco, who's going to join us this morning. And she's going to be conducting this first summit for the folks who are on the grounds out there working with people who have mental illnesses or substance abuse disorders.